How addressing pre-op challenges optimizes your outcome. Here is a case of phacoemulsification in 84-year-old male patient with many challenges like small pupil and pseudoexfoliation with expecting of weak zonule and very dense bronze cataract as we can see. I started with 2 paracentesis and 2.4 clear corneal incision, applying HBMC over the cornea. Then staining the anterior capsule using the capsule blue. As we can see, the pupil is very small, so I introduced the cannula slightly under the iris to stain the hidden area of the anterior capsule, followed with wash out of the capsule blue, as we can see, with gentle pressure over the iris to push the capsule blue hidden behind it, as we can see. Then, as we can see, the pupil is very small, so injecting dispersive OVD, prepare the eye to implant the Malugin ring to dilate the pupil. Here is the Malugin ring. It's preloaded, then inserting the first eyelet in the iris border, the lateral eyelets, now the final eyelet using the forked instrument, as we can see. Now I have very good dilated pupil and the anterior capsule is stained well. I testing the anterior capsule using the capsule rixes. Here I'm going to apply the capsule laser to help me in creating a very good centered capsule rixes, which is 5.4 millimeter in diameter. Then removing the rixes. As we can see, the cataract is very dense. It's bronze and brown. And here is the hydrodissection with gentle empty of the anterior chamber from the viscoelastic to be sure that your hydrodissection is complete. I'm going to rotate the nucleus. Now the time for the emulsifying of this dense nucleus. As we can see here, I'm going to use a horizontal chop technique, holding the nucleus, split it in 2 halves, then trying to split each half into small fragments. As we can see, here's the second half. Now I have 2 quadrants. As we can see, the cataract is very dense, and one important step here is to inject the viscoelastic many times during emulsifying of this dense cataract to protect the back of the cornea. Here is the first quadrant. After chop it into small fragment, then rotate the nucleus and try to emulsify the second quadrant. Hold and chop into small fragments, then emulsify, as you can see. Also now continue chopping of this dense cataract. Here is injecting of the dispersive OVD to push the posterior capsule back and also to protect the back of the cornea while emulsifying this dense nucleus. Here is the last fragment or last quadrant. Now everything was done properly. It's the time for bimanual irrigation aspiration. Here is the problem. You can see the cortex is very stick with the posterior capsule, and also you see I observe the wrinkled posterior capsule, which is a sign of weak zonule. As we can see, the posterior capsule, it comes all the time towards the aspiration probe. At this time, the capsular tissue ring was prepared for implantation. Before taking out the irrigation probe, I inject cohesive OVD to form the capsular bag, as we can see, to prepare the capsular bag for CTR. Here is the CTR implantation with assisted by the other hand using the Sinsky. Then I complete wash out the cortex, which was slightly difficult because it also stuck with the CTR. Here we can see another evidence of weak zonule. Actually, I want to hear from you in writing some comments. What is the second evidence of the weak zonule during this type of phacoemulsification? In this case, here is completing the cortex removal. Now it's the time for implanting the IOL. Actually, I'm going to implant 3-piece IOL in this case as there is weak zonule in this patient. So I enlarged the main phaco incision. Here is the 3-piece IOL. I'm going to put the haptics in the sulcus with optic capturing the capsular rhexis, which I usually prefer to use this technique in patients with pseudoexfoliation and weak zonule. Before wash out the viscoelastic, it's the time. Here's capturing with the anterior capsule. It's the time for removing the Malugin ring. In the same manner, just releasing the first eyelid, then by the final eyelid using the injector of the Malugin. Now we can see the haptics in the sulcus and wash out the viscoelastic. Here is the end of the surgery. Now stromal hydration for the paracentesis and main phaco incision. And here is the end of the surgery. We can see the patient now on the next day with cornea almost clear, and vision of this patient improved to be 20/28, which is a good result. And thank you for watching.